And colleagues in the audience, I'll be presenting my study comparing intralesional and oral propranolol for treating periorbital and eyelid capillary hemangiomas. Infantile hemangiomas are one of the most common tumors in the infantile age group till the age of 7 years. Oral propranolol has received FDA approval in 2014 as the first-line therapy for periocular hemangiomas. However, there is limited literature on the role of intralesional propranolol in the periocular lesions. With this in mind, we designed our study as a prospective randomized interventional study, which was carried out at Dr. Rajendra Prasad Center for Ophthalmic Sciences, New Delhi. After obtaining ethics clearance and prospective CTRI registration, we included 20 patients who were less than 7 years of age, who were treatment naive, whose guardians were consenting, and who had periocular lesions without any intracorneal extension. At baseline, a detailed history and clinical evaluation was done with specific documentation as to the lesion location, surface area, color, and elevation. Investigations included keratometry, ultrasonography, and contrast-enhanced MRI to rule out any intracorneal extension. This was followed by a pediatric cardiology clearance, after which the 20 patients were randomized into two groups. Group 1, that is case 1 to 10, received oral propranolol at a dose of 3 mg per kg per day for 6 months. Group 2, that is intralesional propranolol, received propranolol hydrochloride injection with the dose calculated as per the longest linear dimension of the lesion at day 0, 6 weeks, and 12 weeks. Continued follow-up was maintained and the final evaluation was done at 6 months. Our primary outcome parameter was percentage reduction in surface area, which was further categorized onto a scale with excellent reduction being greater than 90% and a poor reduction less than 30%. The secondary outcome parameters included regression in color and change in elevation. In addition to this, we monitored the patients for side effects in the form of systemic side effects or local. At baseline, the lesions were characterized into 4 major types. Majority of the patients had a deep extensive lesion. 5 patients had a skin surface localized lesion. Another 5 had a conjunctival surface localized lesion. And 2 patients had a skin surface extensive lesion. We also calculated the longest linear dimension using a digital caliper. Using this dimension as the length and the dimension perpendicular to this as the width, we calculated the surface area of the lesion at baseline and at subsequent follow-ups. We also categorized the lesions on the basis of color and elevation on a subjective scale. The representative images for the same are depicted here. At baseline, both groups were well matched statistically, making the randomization adequate for our study. Coming to the first group, that is the oral propranolol, there was a greater than 80% reduction in the surface area at the end of 6 months with significant improvement in color as well as elevation. These are the serial follow-ups of case 5 and case 10. 3 patients reported side effects in the form of poor feeding and lethargy. However, these were not significant enough to warrant any discontinuation of treatment. Moving to the intralesional propranolol, this group also showed a statistically significant reduction in the surface area at 6 months at a value of about 67%, with improvement in color as well as elevation. The representative cases, case 16 and case 20, are depicted here. None of the patients in this group showed any side effects. On a statistical analysis with a p-value of 0.056 in my study, intralesional propranolol was comparable to oral propranolol for treating these periocular infantile hemangiomas. Coming to a few case summaries, in the oral propranolol group, if we look here, there's a dramatic improvement at 6 months with an excellent response of greater than 93% in this patient. Compared to this patient with a superior-nasal orbital mass has an improvement, however, the lesion still persists at 6 months. This is a moderate to good responding case of about 67% improvement. Moving to the intralesional group, this child had a dark red elevated lower lid lesion. After 3 injections and a follow-up at 6 months, there's an excellent response with a hardly perceptible lesion of a reduction of greater than 90%. Compared to this child had a superior orbital lesion. Despite 3 injections, this is a poor to fair responding case of about 31% reduction. Seeing the varied response within the intralesional group, we decided to retrospectively compare the 5 patients who had a greater than 70% response, that is very good to excellent, compared with the 5 patients in group 2 who did not have such a better response. We realized that lesions which were small, localized at baseline, responded better with intralesional propranolol. To summarize, this is a randomized controlled trial with 20 patients and a follow-up of 6 months. In this study, intralesional propranolol is statistically comparable to oral propranolol. In addition, small localized lesions responded better with intralesional propranolol, and there were no side effects in the intralesional group compared to 30% of the patients in the oral group having side effects. The biggest strength is this randomized controlled trial with a follow-up of 6 months. However, given the rarity of this condition, the sample size remains small. Also, the need for general anesthesia for group 2 is a major limitation in our study. I would like to recommend that intralesional propranolol can be considered a first-line therapy in small surface localized capillary hemangiomas. It can also be considered an alternative in patients already on oral propranolol showing significant systemic side effects. Thank you.
Thank you, Aditi. That's a wonderful study. I have a question for you. How did you randomize it? Because it's kind of unusual to have 10 in each group. So what method of randomization did you use?
Ma'am, we used a computer-generated random number table. In the oculoplasty clinic in the place of study, the average number of patients with capillary hemangioma presenting is about 5 per month. We had to include only the treatment-naive patients, so some of the patients were excluded, but consecutive patients who were then recruited and then using a random number table, we randomized into 2 groups.
The lesion morphology did not make any sense, is it? Because one of the surface lesions which had multiple ones, wouldn't it have been difficult to inject into each of those?
So at baseline, the lesions were actually randomized. When we compared, the 2 groups were randomized for lesion appearance, location, and size as well. In the intralesional group, the dose was calculated as per the longest linear dimension. So a larger lesion was receiving more dose as compared to a smaller lesion. So that effect was taken care of.
Just a question of the injectability. So many multiple lesions were there. Would it have been possible to inject into each of those lesions is what I was thinking.
So definitely, if it's a multiple lesion, if multiple sites are involved, oral propranolol seems to be a logical answer. However, if supplemented with intralesional, the patients may not require the oral dosing for a long time, and we can avoid systemic side effects.